first sour, whether you have subsequent tower or you do valve and valves, because and if people are going to live longer, we need to give them therapies which should be durable, not just a one-time therapy. So most certainly, these are growth areas. The tricuspid, now we were only doing cable management, which was not really great, but today with the tricuspid, the H2H repair, as well as there are predetermined valvular options for the tricuspid valve, it is growing. What is PFO closure is of course great. And if Samir had been here, he would have told you that a fellow who worked with him in his last meeting, which Naveen sir and I attended, the boy came up and he made a presentation and he had a stroke thereafter. And then they discovered that he had a PFO. And now subsequently that's been closed. So PFO closure is okay. If you are a follower of one of my gurus, who's John Mandrola, then you probably the closure here, which was reported at the TCT this year, actually put a question mark on left atrial appendage occlusions, and it should certainly not be a routine. And because DOACs work quite well, but in patients who cannot tolerate DOACs or NOACs, then we should consider a left atrial appendage occlusion device. So structural interventions are increasing. They're becoming commonplace. They're becoming something which is part of our lexicon and part of our armamentarium. And I think that was a very elegant presentation, Harsh, and well, good work. Back over to Professor Sinha.
Yeah. Thank you, Dr. Sananda. Thank you. I got cut off, but that was a very good story that you told me you met Dr. Trippier. I never met him. But as you said, sir, the tricuspid interventions, we are doing evoke valves now in the tricuspid space. So that has evolved a lot. And then, yes, the new trial from the AHA did show the inferiority of left atrial appendage closures as compared to DOACs. So that limits its use for sure. It's been going on.
The skeptics in cardiology, I would urge them to follow one podcast which comes every week. It is by John Mandrula. It is on Medscape, the heart.org. It is the week that was. And as far as I'm concerned, I follow it like a religion. And you'll get to hear, see, he's been a skeptic who's always said that we were doing far more, and they are doing far more left atrial appendage occlusions than is probably warranted by the data. So he was very happy, I think, when the closure bombed. So
yes.
I think certainly the applicability of these procedures in very sick patients who are very high risk for surgery or anesthesia, they may be having ILD or something where they cannot be ventilated, multiple comorbidities, CKD, etc. And sometimes we observe dramatic benefits, at least symptomatically. And I mean, fine, durability is an issue. But then if you're doing it in a 75 or 80-year-old, you are looking at the next 10 years. You can't say you are looking
I think the algorithms of indications need to be defined clearly. We have few patients with atrial functional mitral regurgitation, and we are really challenged to see whether this patient, because you don't want to send a patient through, say, it's an expensive procedure. In India, cost of a mitral clip would be 27 lakhs, which is enough, which was enough a few years ago for people to buy a house for themselves. But then we can't also be, we can't also be very comfortable with the fact that it may not work. So you can't. It might not work. So you got to and in India, if a patient comes to a physician and the therapy, even if done well, does not work, the patient thinks of it as a failure. He thinks of it as a complication. So we have no second guesses here. What we have to do should work. Unlike an insurance-based system in the United States, which is where people come back for a redo with great ease. So many procedures in India have got limited because of this problem, because you can get somebody to come and spend 27 lakhs first time. But if you tell them after 2 years, we need to probably
Right.
look at it, there is a leakage, we need to go back in. Then they're going to think that the doctor is probably very much in this game for his personal benefit. So those
Exactly. Yeah.
those are
That's
challenges.
a big problem. Yeah.
So those are challenges in our ecosystem. However, we need to improvise. We need to learn. You will be pleased to know that many Indian companies are now have tied up with some European companies for different valves, and some with Chinese companies.
Right.
And these are valves which are, there are some indigenous valves. Everybody knows about the MyValve story from Merrill, which is doing very, very well. As we all know that there could be some challenges with their, but those are legal hurdles which they have to cross as far as the game with Edwards is concerned. But we have a lot of offerings available today, even in a more comfortable financial space. So, which I think is how medicine and the practice of probably valvular intervention needs to get democratized as much as coronary interventions have got democratized over the years. I mean, when we started putting in one stent, bare metal stent also was a challenge. Used to say, if there's restenosis, the guy's going to have to sell his house. Then it came with drug-eluting stents. And then we started putting multiple drug-eluting stents. And today, we are comfortable with advising them into coronary imaging. We are comfortable with advising them and intravascular lithotripsy, which is
Right.
a cost in arm and a leg. So I think it's a matter of time when insurance penetration increases, when the government support increases, that we will also be on top as far as structural interventions are concerned. There was a big delegation which was at London Valves just last week. So I mean, I just know from the Facebook posts and all the other. So there were a lot of people there who put up their photographs. So that means they've traveled. So a lot of structural intervention is indeed happening. We need to refine our algorithms of care and our indications so that we give maximum benefit.
100%.
Thank you very much, Harsh. And
Thank you, sir.
Yeah, I mean, we'll be very excited to know of future developments, perhaps a couple of months again when you come and visit us in India.
Yes, sir. Thank you. And thank you, everyone.
Thank you.
It's a big honor. Thank you.
Please give him a big hand.
Thank you, sir. Bye.
Right. Bye. So I think with this, the very intense discussions have come to a temporary pause, something like an interval till tomorrow morning. Tomorrow we'll be starting at 10:30, and we have few very interesting discussions and presentations lined up. So if you have enjoyed today, I think you will enjoy more tomorrow. Enjoy your dinner. Enjoy it's just on this side, and